And a very good morning. It is 11 o'clock. We're going to go ahead and get started. First and foremost, welcome to today's presentation, Self-Funding 101. I am your host and moderator, Arwen Robinson with Advanced Benefits, and today we are very excited to take you through this presentation this morning. As you have questions during the presentation, please utilize the chat function. We will have a Q&A period at the end of the webinar today, where we will address any questions that were not answered during the course of the presentation. This presentation is being recorded. If you do not wish to participate in a recorded call, please disconnect yourself at this time. This presentation is a courtesy service to our clients and our dear friends. It is designed only to give general information on the developments actually covered and is not intended to be a comprehensive summary of recent developments in the law, treat exhaustively the subjects covered, provide legal advice, or render a legal opinion. Advanced Benefits and employees are not attorneys and are not responsible for any legal advice. To fully understand how this or any legal or compliance information affects your unique situation, you should check with a qualified attorney. Last but not least, most importantly, I would like to introduce our presenter today, James Perkinson, Account Executive with Advanced Benefits. James is a registered employee benefits consultant and a certified self-funding specialist. James has been with Advanced Benefits since 2019 and brings years of insurance and financial advising experience to today's presentation. Without further ado, there we are. James, you have the floor. Now, I know that your laptop just decided to restart prior to the presentation starting. So I just want to make sure that you have your mic and camera are all up and running.
Thank you, Arwen. Can you hear me okay first? We'll do a little sound check.
Yep, I can hear you just fine, James.
See that okay?
Sure can, James. You are in good shape.
Perfect. Well, first of all, I just want to say thank you very much for everybody attending and giving me the opportunity to speak here today. This is very much a passion of mine, talking about self-funding plans. And so I am very excited to speak today, walk through this presentation. My hope and my goal is showing the different components of self-funding, and that when we talk about self-funding, it's not as scary as some might make it out to be. So with that, we'll kind of dive first right into just the agenda of what we will be covering today. And so we'll start by talking about the differences and similarities of fully insured and self-funded. We'll break down what are some of the components of self-funding. So what are the different parts that make that up? We'll do a high level of some of the self-funded terms that you will hear. So hopefully you get some familiarity with some of the terms that are thrown around when you're specifically talking about self-funded. We're going to go through, talk about the highlights and considerations of looking at a self-funded plan. Plus, with all this work that you're doing, what's my return on investment if I do choose to go self-funded? Lastly, we'll really wrap up with talking about who is best fit for self-funding as an employer here. So with that, very excited to get going. And so we'll start with the next slide here. I really want to start talking about self-funding in an analogy standpoint. And really, when we're looking at this here, one of the things we're looking at is renting versus owning. We'll go with a vehicle because I love, and one of my dream cars is the Shelby Cobra Mustang here. But essentially, to start off, when we're talking about health insurance plans, one of the things we talk about is renting a car versus owning a car, right? The equivalence that I would say is renting a car is very similar to being fully insured, where essentially renting a car, right? You show up, they give you the keys, it is ready to go. Any problems or issues that you have is really going to be on the rental insurance company, right? You're not worried about maintenance, you're not worried about anything like that. It's simply just a very convenient piece there. But with that, typically your costs can be higher. You're out of the control of what are the components of renting a car, such as the insurance, maintenance, all those things. They are just wrapped up in that rental agreement that you have there. Whereas on the flip side, owning your car, which I think most of us really do, you think about all the different components of owning your car and how that's broken out, right? You have your monthly payment, you have your insurance payment, maybe you have a warranty to protect yourself in the event of an unfortunate breakdown, things like that. The other component of being able to own your car as well is the fact that, if you want to get some better gas mileage, maybe you change out that cold air intake so you get the car breathing a little bit more to get some. If you're looking for a little bit more, racy vibes, maybe you do a better suspension, things like that. But you have that availability to do that because you own your car. At that same time, though, when we talk about self-funding, we're going to go through this in future slides here. You can also go and purchase that same car that you have from a rental standpoint and purchase a lot of the same things, like I said, a warranty or something like that, in order to protect yourself from some of those potentially costlier things by owning your plan. So to bring this back to fully insured versus self-funded, fully insured is very much like renting a car, right? You show up, the insurance carrier, they tell you, here's the premiums, the price that you would pay for renting, this insurance plan, if you will. And essentially you're using it while you have that there. And let's say things get a little expensive. You can either change cars, you can change, how long you're renting it for, things of that nature. Whereas really when you're owning it, you have a little bit more pride and ownership of what is your maintenance schedule? Are you getting your oil changed? Are you doing those kind of things in there? So we're going to kind of go through this renting versus owning a vehicle theme throughout this presentation here today. So the next part is components of your health insurance plan. So whether you are fully insured or self-funded, a lot of these components are exactly the same. Now, going back to that renting of a vehicle, it's all typically bundled in together. So these aren't necessarily things that you would see, but these are still components that make up the fuel that runs your health insurance plan. So typically your third-party administrator is who is the claims administrator, who is processing the claims, paying those claims for your employees when they drop their ID cards. You also have a pharmacy benefit manager. So that's typically wrapped up together with that third-party administrator. You also get a network, right? So when we say, hey, is this in-network, out-of-network, that's typically bundled in there together with your fully insured. And that's one of the things that you look for when you're fully insured, right? Is what is my network access for my members? Also in a fully insured contract, you do actually technically have stop loss insurance covered on that fully insured contract. If you are an experience rated group, typically what you will hear from that perspective is a pooling point, right? So if you're going through at renewal time typically, and you're looking at what your renewal calculation came to, one of the line items that you will typically see on a fully insured renewal is a pooling point. That's going to be equivalent to one of the terms that we're going to talk about in the slide with the self-funded terms, but just want to point that out that there is that point that's in there. There's also just various tools and vendor partners that fully insured carriers will work with. So typically you'll see things like telehealth, diabetes management, things along those lines that fully insured carriers will also provide built into there. So why does this matter, right? Is there's different components, and sometimes you want to have higher octane fuel to get things going a little bit quicker and running smoothly, right? So we talk about choosing the gas that you want. I'm going to flip back actually and say each one of these pieces, typically when we're talking about self-funded, you can purchase this whole thing in a package deal as well, very similar to fully insured. You can typically go to a carrier and they can bundle all of this together. The advantage that you also have is says, hey, prescriptions is maybe something that we want to help tackle. We want to put some higher octane fuel specifically behind our pharmacy benefits managers. And we want to do something a little bit different, right? So similar to owning your vehicle and you want to swap out the suspension, the tires, the exhaust, whatever it is we want to do, you have that availability of doing that on a self-funded plan. So the reasons that you would want to do that is taking a look at what are some of the options that you have and what are the components that make up your plan. And so we talk about that high octane fuel. And so if you're looking at your plan and you're like, this part of this process or this plan isn't working for me, you're able to swap that out essentially and plug in a new component that works in there. So when we take a look here on the left-hand side, you'll see kind of the fully insured and the self-funded model. One of the things to kind of point out here is on the left-hand side, that is your total premium that you're paying. That's 100% fixed cost because, again, being bundled in together, you are still paying those same third-party administration expenses. You are paying that stop-loss premium that's bundled in with that fully insured contract. And majority of the premiums that you are paying do go towards paying for your claim. So when a member drops their ID card, it's the insurance company that's typically paying those claims for you. Whereas on the right-hand side, by unbundling some of those things, you have more control over each of those different pieces there. The other piece that I want to point out is when you look at on the right-hand side, only typically 20 to 30% of your health spend on a self-funded plan is in that what we call fixed cost category. The rest of it typically is a variable cost in there. We're going to talk a little bit more about that variable cost component and the potential swings, if you will, of having a variable cost in there in a future slide. But what this is really trying to illustrate here is on the left-hand side, that's 100% a fixed cost that is money going out the door. So if you do have employees that are shopping their healthcare experience and being good consumers of their healthcare, and that claims bucket gets lowered, you are still paying 100% of that premium over to the insurance carrier. Whereas on the right-hand side, if we're educating and teaching employees how to be good consumers of the healthcare, and we'll talk about more about those components in a future slide as well. If you can teach employees to be good consumers, whether it be, we talk about the carrot or stick approach of, hey, if you go to this provider, you're actually going to have less out-of-pocket experience there than if you go to this other provider. And that's where you see that top potential plan savings there is by being good consumers of healthcare and navigating the healthcare system in a correct manner there. So I do want to talk a little bit about self-funded terms. So these are some of the common terms that you will hear when we talk about self-funded plans. And so when we talk about self-funded, one of the things that you want to purchase is what's called stop-loss insurance. And what that essentially does is help protect you and your plan from high-cost claimants is essentially what that does. And that kind of works in two different functions. One is a specific deductible. And so we talk about belly buttons, right? Whether that be an employee, a dependent, or a spouse, belly button on your plan. So specific deductible, for example, might be $50,000. So as a self-funded plan, because you are paying those claims as they come through the system, the stop-loss insurance is essentially there to say, hey, if your deductible is $50,000, you're going to pay zero or members out-of-pocket maximum to that $50,000, and then that's where that stop-loss is going to take over from there. On the other side, let's say we have a field trip with our employees. There's a bus accident, if you will, and now you've got 15 employees that have claims that are under that $50,000 specific deductible. That's where this aggregate deductible comes in and helps protect many lives that are underneath that specific deductible to help in that event of large claims that are below that specific deductible number, but still make up a larger amount than we want to spend on our plan in a given year. Another piece that might be new is what's called accommodations, and this works both for the specific and the aggregate deductible. And essentially what the accommodations are saying is typically with a specific deductible, if we say that $50,000 mark there, the accommodations would say the third-party administrator is going to stop claims at that $50,000 mark, and then they're going to go work with the stop-loss insurance carrier to go get any reimbursements above that amount there. In other arrangements, if you don't have accommodations, typically your account's going to get swept for anything above that specific deductible amount, and then you will need to go to the stop-loss carrier to get those reimbursements and prove eligibility, and that's a little bit of time there. On the aggregate side of things, how that's a little bit different because it's spread out over many lives is typically there is a funding mechanism that says at a certain level on a monthly expense ratio, this is the most that you will pay. Anything above that will essentially roll over to future months. So in that way, in any one given month, what your max liability would be. Now, let's say that max liability is $150,000. You have $200,000 worth of claims in a given month. Essentially, what's going to happen is that additional $50,000 is going to roll forward to that next following month. And let's say you only have $40,000 in claim that following month. Well, now because you have that aggregate accommodation, that $50,000 plus the $40,000, still under your $150,000. So you are all good, and you are not potentially going to make your company go bankrupt. A next piece for consideration is looking out for lasers. And so lasers, an equivalent is, I don't have homeowners insurance. I accidentally, let the barbecue get too long, and now I've got a fire, and fire catches onto my house. I'm not calling my insurance company up at that point to try to get insurance at that point in time. And so lasers are just a way for stop loss insurance companies to say, hey, we know X member is having some sort of high cost that's going on. And so we will target that individual. Instead of a $50,000 laser, you might have a $200,000 laser specifically on that member. Now, one of the things that you can do and negotiate on a self-funded plan is dialing in what that laser entails, right? So instead of the laser just being on this member, this person, for that specific deductible increase there, you can dial that into a very specific procedure or diagnosis or something like that, right? So for an example, we have member X, we'll call them. Member X is going through cancer right now. Their treatment is about $300,000 a year. So stop loss looks at it, says, hey, we're going to put a $250,000 laser on this member. If you can tighten that up and say, hey, this is just specific to this cancer treatment, something like that. Let's say member X has another accident. They're out hiking. They trip, fall, break their leg, have to get life flighted, something like that. That is completely unrelated to that cancer treatment. And if you have the language that's built into your contract there, you can actually say, hey, this is going to be subject to our $50,000 deductible, not that lasered amount, because it is something completely related to what that laser identification specifically is. So one of the things to look out for when you're looking at your contract when exploring self-funded. The other piece I want to talk about is contract terms. And so I don't want to dive too deep into this one, but just knowing and understanding. Typically, you see a 12-18 contract, and what that's simply indicating is incurred versus paid. So when a member drops their ID card, as we all probably have experience in the healthcare system, right? I go to the doctor today, I drop my ID card. I don't actually receive an explanation of benefits from my insurance company for probably close to 2 months roughly, right? And so in between that, that's kind of what we call lag time. And so in a stop loss contract, a 12-18, for example, is incurred in 12 months, so during your contract period. And then the 18 months is essentially a 6-month tail for when that would be paid for, right? So let's say January 1st contract renews. Let's say one of our members goes to the hospital in December, right? Most likely the provider's not going to send that to the third-party administrator for at least a month, maybe 2 months, right? And that's past our stop loss renewal date. If we have a 12-18, it's essentially saying that, hey, we have an extra 6 months for that claim to get paid, processed, and stop loss will cover that. The other side of the coin is typically that's called a run out contract. You have a run in contract where it's looking at claims that were incurred in the previous 24 months, and paid in 12, right? So in that scenario where somebody went to the hospital in December, your contract renews, it gets paid out in January, February, it's a new contract. Well, if you have a run-in contract, it's looking back at that previous contract, showing that it gets paid, and now it's going to be covered under that new stop loss policy. So just be cognizant of what contract terms you're looking at, because there are ways to make that less expensive if you're taking on more risk based off the contract terms. So let's move on from terms and let's start talking about range of self-funding, right? So when we say self-funding, that can be a very broad spectrum, right? One of the things we talk about is health reimbursement accounts, so HRAs, and I'm sure a lot of people have heard about those. And essentially what that is you're setting up parameters for a member to go get care and a pot of money that's set aside over there. Once they submit for reimbursement, they would get a portion back. That is a form of self-funding because you were saying, hey, if you go get services, you return your receipts, we will pay you whatever your contract is stated there. Now, you're least at risk because typically you're setting up parameters where it's only a couple of $1,000s that you're paying. You're also contingent upon, the members actually submitting their reimbursements and getting the proper paperwork in. To the next level down below is level funded. So this is a great bridge, if you will, to go from fully insured to not quite self-funded yet. This looks and feels a lot like fully insured, where you get fixed premiums. But the deal is typically you'll have a contract in there where if your claims amount is below the amount that's set by the actuaries or underwriting, you are in a shared arrangement typically with the insurance company, right? So if they have $1 million claim spend for you, but you only spend $750,000, that is great. That means you are below there. In a fully insured contract, they're going to take that. They might give you a rate pass and say, thank you, come again, right? Level funded, depending upon your arrangement in your contract, you might have a 50-50 split, right? So in that $1,750,000 example, that's $250,000 worth of unspent claims dollars, essentially. And if you are in a 50-50 arrangement, that's a $125,000 check that could be coming back to you. And that's what you get in a level funded program. There are typically some mechanisms for cost containment in there, but it is a nice bridge and a gap to get over that might be able to help fund, an account for you that helps move you into that self-funded model. Next is more of that captive layer. And captives are really built for employers that are 50 to probably several hundreds. And it's essentially built to be a shock absorber, the shocks of aggregating like-minded employers together to go and purchase contracts together. Captives can be a great arrangement for some of those mid-sized market groups, specifically because you're being able to work with and talk to other employer groups to find out what's working for them or what's not working for them. How are they communicating? How are they going about rolling out programs, things like that. There's also the piece of, the rule of thumb typically is you're going to have a bad claims year about once or twice every 5 years, and typically about 3 years out of every 10. And so in the captive arrangement, that you are basically trading off. Some years you're going to have bad years, some years you're going to have good years. And those good years, you're helping some of those people who are not having great years. And then the flip side, when you're having a bad year, that people are having better claims years are giving you a little bit of grace. Now we put stop loss piece in here because you can go self-funded and you can go purchase that specific deductible. You can go purchase the aggregate deductible, all the accommodations, and you can do this on your own. The next phase that we talk about is something that you might have heard of is reference-based pricing. That's essentially saying Medicare reference pricing and going up from there. Now, typically reference-based pricing has a lot of cost savings opportunities there, but you're also going to potentially hear a lot of noise. One of the things that we're hearing a lot of in this space is trying to get ahead of rather than reactive. And so knowing if a member is going in for surgery, we're proactively contacting the hospital or the outpatient surgery center and seeing if we can do a case rate, pay cash before the surgery is done. So in that way, we're locked in at those set prices, the hospital gets paid quicker, and the member's not experiencing any turbulence on the back end of reference-based pricing. And then once you get to a big enough size company, so the Coca-Colas of the world and stuff like that, they're probably fully self-funded, meaning they're not really going and purchasing a lot of those fixed cost specific deductible, aggregate deductible, things like that, because they have a large enough pool and cash flow essentially to be able to avoid paying those fixed costs there, and they're in the driver's seat of what claims that they have coming down the pipe. So all that to say, to wrap up this slide specifically, is when we talk about self-funding, there are many different avenues and choices to go with this. And this is really where, having that consultative approach to come in and say, what is the good fit for me in direction and stepping stones to get where I want to be. So one of the things, when you're considering this is some of the considerations. So one of the things to look at is financial stability of your company. Right? What is the cash flow that you guys have on hand? And so if you are a very seasonal company, you have a lot of waves where some months are a lot leaner than other months, maybe having some of those accommodations will be in there so you know what your max liability is and it fits under that threshold of your financial cash flow model moving forward. Risk management side of things, now I refer to this one to when I sign up for my 401k or any kind of investments, one of the things that they like to do is give me a risk tolerance questionnaire, really, right? They're asking about what is my tolerance for the variability of the stock market. And it's very much the same on a self-funded plan, is you do have a lot of variability in the claims that are coming. One month you could have very low number of claims that are coming in because maybe members aren't going to the doctor. They're too busy enjoying summertime that they're not going to the doctor, right? More towards the end of the year, when people have accumulated up to their deductible or out-of-pocket expenses, now they might be going in and getting that surgery that they've been putting off for a while because they're close to their out-of-pocket maximum anyway. So typically, we do see some higher claims towards the end of the year because people are realizing that they've hit their deductible, their out-of-pocket maximum. So they're trying to utilize and maximize their benefit. All that to say, from a risk management standpoint, is when you're looking at your claims chart, it might look a lot like the stock market, where some months are going to be a little bit higher, some are going to be lower. But at the end of the day, you know how it balances out in that long-term projection of why we're investing in becoming self-funded. Another consideration is really the administrative lift. And this can, again, vary between if you're going and trying to purchase that rental car and have a similar experience, but you also know that more times out of not, I'm actually going to win being in that self-funded model because of those pieces that you put together. There is still a component where if I start to swap out suspension or the exhaust or things like that, that can result in a little bit more of an administrative lift. And that might be simply paperwork, that might be communications out to your employees about different programs that you're offering, things like that. So that is a consideration that you want to look at from an administrative side. I also threw control over plan design and premium. So one of the things that's in there is, because being self-funded, you are essentially given here is your maximum liability and here's everything below. Typically, we set target fund rates that will go into a separate bank account, and it will act like a fully insured premium. The benefit side of that is if you spend less than that, that money stays in your bank account rather than going to the insurance company and profiting them. So with that, after you've had a couple of years of experience in that self-funded model, we have a lot of groups that start to predict, forecast, and look at what do they have in that accrual account set aside on their premiums, and they might get a little bit more lean on their health insurance premiums, knowing that they have a set of money set aside for some of those bad years, that they have essentially some reserves to help pay for that. There's also the feature of being able to look at plan design, and this can be something that you look at, and let's take chiropractic, for example, right? Typically, you're going to have a set number of appointments that you have in there, and you're able to, as a self-funded plan, go in there and change small components of that plan design for you. So maybe your plan currently allows for 12 chiropractic visits a year. You want a self-funded plan, you can say, well, maybe I want to bump that up to 30. Then you're looking at, okay, if I bump that up to 30, what is the potential cost of doing that? And what is the benefit side of things, right? Everything is a cost and a benefit. And so being able to have that control over your plan design all the way down to something as simple as a chiropractic adjustment is one of the things that you get to choose developing your self-funded plan. Now, the piece that we talk about is, okay, all those different components of a self-funded plan, why would I do it? What is potentially my return on investment here? And so we talk about return on investment. The biggest thing that I like to say is we are able to do data-driven decisions on what our plan is moving forward. So a few examples of that is implementing cost containment tools. So right now we're seeing the top 3 claims drivers right now is cancer, heart disease, and diabetes. Now, typically on a fully insured chassis, you don't have many vendors, if you will, that are helping out specifically with these categories. Typically, you might have a case manager who helps somebody kind of navigate the network with the plan, but they're not truly helping the member's experience or their claims amounts here. And so some of the examples that we've been able to implement with some of our self-funded groups currently is a cancer solution that does 2 things. It helps make sure that there's a right diagnosis and a right treatment plan. And that's twofold. That helps the member experience, because if they get diagnosed incorrectly, they go through a treatment plan, find out that it's not working. Now they're going back to ground zero and potentially a new treatment plan for something that didn't work in the first place. It's a bad member experience, as well as that is very costly to the plan. On the other side of the coin is having a designated vendor partner who specializes in cancer can do a lot more things with cancer support, making sure people are, getting wig support. Maybe there's support for the family members, things like that, that help in the situation of going through a cancer situation. Next being heart disease, that's a little bit more typically a lifestyle thing. And so that's where you can develop, whether it be wellness or nutrition, anything like that. Diabetes management, that's a little bit of both a medical side of things, as well as potentially from a prescription sourcing solution there, which rolls into our next one is, right? If we look at what are some of the prescription issues that we have, I just saw a slide a week or so ago that talked about the inflation rate of medical versus RX. And for the first time, RX is actually starting to outpace medical side of costs when it comes to health insurance plans. And a lot of that is really driven off of, these medications, these injectables, these specialty medications that are coming out and doing some amazing things, right? They're able to go in and help people who have, say, cystic fibrosis, some things that have previously been very harmful and potentially deadly to members. And so the fact that we have programs that are out there that are helping families out that way is tremendous. But with that also comes the cost of that. And we're seeing medications in the millions, $2 million, $3 million. That might be a one-time, or it might also be an ongoing medication piece there. So one thing that you're able to do is say, okay, well, if cost of medications are just constantly increasing, what are some programs that we can do? So some of the typical ones that we do are some mail order programs, right? Being able to cut out some of those middlemen and go directly from drug manufacturer right to your member's doorstep, help save the plan, help save the member. There are also some specialty programs where you might be able to maximize different programs that are out there specifically to specialty medications, because those are typically your high cost ones. And they have programs set aside to help members who, the federal poverty limit is typically what those programs are built off of. And so we're able to help maximize those for members so they're not having to spend, up to their out-of-pocket maximum for a medication that might save their life, right? The last thing I want to say is data-driven decisions on price disparity is, this is one of the exercises that we've personally done, is just seeing surgeries in our area. And this is a great example of, the same surgeon inputting the same parts into somebody, and price tag at hospital A is potentially $60,000 plus versus hospital B being sub $20,000. And really the main difference is the hospital fee that they're charging for a lot of these procedures in there, right? Health insurance and health in general is a little bit of opposite of, say, buying a car. Typically, you expect if I'm going to pay more money for a car, I'm going to get a better quality and a better experience, right? Healthcare has shown that there is quite an inverse relationship to that, right? That actually you're going to have a better experience, a less readmission rates, things like that, if you're going to a lower cost provider. One of the issues specifically in this is there's just not good sources of data for members specifically to try to make smart decisions. And so this is where we talked about the carrot and stick approach, where maybe we plan design to send members to hospital B because we know that savings potential is very great. So we might save the member $2,000, $5,000 out of pocket, knowing that by going and getting a surgery at hospital B, the plan on the back end is going to save potentially $40,000. We also see this in the prescription side of things, right? A common medication that we see is an antacid and an ibuprofen magically mixed together, and now a single pill costs $300. When you just take it apart and you say, if you go buy an over-the-counter antacid and an over-the-counter ibuprofen, you're going to spend $10 maybe max on both of those bottles, not just per pill. And now you have the same results as to what that is, right? But, I was having a conversation yesterday about this specifically in a healthcare worker, and she said, "Hey, I have seen providers specifically write scripts just so the member can run it through their insurance, which is less cost for them." And that is awesome. They're trying to accomplish, a good thing by the member in writing it through the insurance. We also know, hey, you wrote a script for a $300 medication, which simply could have been an over the counter, two different ones mixed together, same results there. This is where we're able to look at those data driven decisions and make those plan design changes, have those discussions about how can we help be more impactful for the member as well as for our plan costs there. So I want to wrap up with our last slide here, specifically talking about who is a good fit for self-funding. Now, obviously, there is a component of size. And so we have programs that go as low as 25 enrolled members on a health insurance plan to be able to have that. So there are considerations with size, but I think that there are other soft benefits that need to be discussed about talking about who's a good fit for self-funding. One of them specifically is company culture, right? When you go self-funded, so much of it is simply just a mindset of how we're going to tackle our healthcare. And the more that the company culture is surrounded around, good, positive communication, helping members, making those decisions that at the end of the day are going to help that member and be able to communicate that to the member, because they are potentially going to experience a different way of going about their healthcare experience if we're sending them to hospital B and saying this is where your lower cost provider is going to be, less cost for them. They might come back and say, well, I want to go to hospital A. And there's an option there where you're able to say, hey, you can go there, but you have to pay, up to your out-of-pocket maximum if that's what you choose to do. There's also the piece that says, no, we know that the hospital here is less expensive, you go there, right? So that's a little bit of like, what's the transparency? What's your level of communication with your members there? Communication is also a next piece, because we talk about, okay, if we are going to implement various tools and things like that, communication is a very big thing to how do you let your members know that there is this diabetes support program? Right. So if you have a communication where maybe you have manager meetings that meet on a regular basis, you're able to drop a 5-minute plug about this diabetes management program. Maybe you have a texting internal system that allows you to send out some push notifications to say, hey, check this out. Maybe you had the link on there. Communication is probably one of the biggest things when it comes to just benefits in general, no matter if you're self-funded or not. Communicating what benefits are out there and what are available is a huge component to any plan at all. Leadership mindset is one thing that I would also be very keen on, is understanding the direction and the investment that we're going self-funded. And if you don't have leadership's buy-in on this, I think you're set to fail from the start. Even if you implement some of the best programs, you need to have that buy-in from the program, from the leadership mentality. So then that way, when you implement a program, you are going to get that return on investment. And hopefully you're able to track what are those key performance indicators that are showing that there is a return on investment for spending on this vendor partner for diabetes management or cancer or whatever that case may be. The employee support is also huge. And sometimes we have various groups that are very open and communicate that they're self-funded. And we have others that don't necessarily communicate that they're self-funded, but they help explain how health insurance works. And that could be another seminar that we do, webinar that we do, is just talking about how health insurance does truly work and who's the ultimate payer for that, right? Because at the end of the day, the ultimate payer is the employer, trickles down to the employee and what comes out of their paycheck. And so if the employees are bought into this concept of being able to utilize maybe mail order programs, utilizing going to the right providers, that's where you're going to have that support. And that's where, at the end, being able to help reward the employees for the right decisions by doing things like giving them a premium holiday, right? If you have money set aside in that claims fund and you're doing well on that spend, you might do what's called a premium holiday, where you say, hey, we're not going to take any deductions for the month of December. You can use that money to buy Christmas presents, whatever that may be, because you're doing a great job being consumers of your health care there. And I ultimately believe that at the end of the day, when you have a good running self-funded plan, you can truly offer better benefits. I say this because we're able to look at the data and say, hey, what if we actually did lower your deductible here, right? When was the last time that a fully insured group actually moved their deductible downwards? It's pretty rare these days, is what I see. A lot of times when you're fully insured and you're facing a high renewal, you're either shopping your benefits to different carriers, you're changing your plan design to increase deductibles, out-of-pocket maximums, copays, or you're going back to the carrier and you're negotiating with different parts of the benefit plan design, shopping out the benefits, things like that. Being on a self-funded chassis, you're able to truly say, somebody walks into your office and says, hey, I just got diagnosed with cancer. If you have one of those cost containment vendor program plugged in, you're able to give them a contact person who's going to specifically help them in that cancer situation, rather than a all-encompassing case manager at a fully insured group there. Ooh, wrong direction there. So in conclusion, we covered a little bit about fully insured and self-funding can look and feel very similar, but you can also change out a lot of those parts, right? If you are a car person and you're just like, hey, I want to add this and tweak that and change out these things because I know I'm going to have better performance, it's truly what you get to do is a self-funded plan. There are different ranges when we're talking about self-funding. So just a general blank word of saying self-funding can vary between HRA all the way to reference-based pricing and fully self-funded. And I also highly encourage you to look at the costs and highlights, as well as considerations in the return on investment that you would have being self-funded on your health insurance plan. So at this time, I will pause and pass it back over to Arwen for any questions.
Yeah, absolutely. Thank you so much, James. I really appreciate the great content. We do, in fact, have some questions, so I'm sure we'll cover some more. So one of the questions that came up, and I think it's very fortuitous considering the deadline for this filing is coming up at the end of this month, was if there's any additional paperwork or filing that is required when you are self-funding. And the very first thing that pops to my head is our lovely friend PCORI.
Yes, so there are some different considerations with filings that you have. PCORI fees is one of them, and that again can range specifically from if you offer a health reimbursement account to fully self-funded. So PCORI fees is essentially a government-funded program to help investigate into different health insurance components there. And so it's a specific fee that you're just paying per member that's enrolled on your plan. And so there are some additional filings. That is one of the things that we do at Advanced Benefits, is by sending out notifications. And that's where internally we tag people who are qualified under a self-funded plan. So you will get those notifications on a regular basis and a timely basis to make sure that you're doing those filings.
Yeah. And we should have a PCORI white paper coming soon to a social media and email near you. All right. Next question we have. What are the implications of changing plan designs, and the fact, how does it impact my stop loss coverage? And this is one thing that I was really glad came up, given that, right, when you're self-funded and everything is unpacked, it does mean that, there's some additional communication that happens back and forth. So if I change my plan design, James, who do I need to let know?
That is a great question. So a lot of that comes back to the contract language of what's written into your plan document. And when I say that, a lot of times what we shoot for is called plan mirroring. And so essentially it's telling the stop loss carrier that we want to match and cover what's on our plan design to stop loss, right? And so when you change plan design, you are submitting those changes over to stop loss, and they're essentially giving the thumbs up when it comes to that plan design. That's a really nice component, because a lot of times if you're going to change plan design as simple as just your deductible, your out-of-pocket maximum, stop loss carrier is not going to really look at that with much considerations, because that's typically just you as the employer being self-funded. You're going to pay the difference between a $5,000 out-of-pocket, and if you lower it down to $4,000, you're simply just going to pay that difference of $4,000 up to your specific deductible. So typically your stop loss carriers not too worried about that. But now if you're going to go and change plan design to say something like, hey, we want to allow, let's say, domestic partners onto our plan, that's something that typically your stop loss carrier is not going to say no about, but they might need to re-rate that. And so there is some potential census adjustments to look at how many potential people are we allowing by allowing domestic partners on our plan. So then you also want to make sure that your plan documents get updated to match that you're going to allow for domestic partners onto your plan. Because the flip side can also happen is if you do not allow domestic partners onto your plan, but you allow one on there and they have a large claim, there are a lot of times where stop loss may come back and ask for eligibility and proof that their enrollment matches the eligibility on your plan document. So there's a lot to that. And so if there's more specifics that you want to dial into, happy to have a conversation on that.
I lost my mute button for a second. I'm like, where is it? Gotta love that. All right. And I think when I in my experience with, the self-funding and stop loss coordination, one thing that jumps to mind that you reminded me of is we get asked a lot, hey, can I cover bariatric surgery? I think that's another one that I hear a lot of that's typically excluded on a fully insured contract. Employers find out, oh, I have this ability to modify it, but a bariatric surgery is very expensive, can potentially have a lot of complications. And so I know that one, especially the stop loss carrier says timeout. We want an opportunity to assess the risk here. So I know that's something else that came to mind when you were talking through, like, okay, what are the implications here?
Yeah, that's a great point, especially right now. Probably one of the hottest topics that are out there, specifically in the employee benefits space, is medications for weight loss. Right, that's a big, I guess, TikTok trend, if you will, about what's called the semaglutides, where it's medications that are specifically, typically they're geared towards more pre-diabetic and diabetics, but people have found that they help you lose a good amount of weight, up to I think 15% body fat. And so that is one of those things that I think we're waiting on a little bit more data to see, is that a viable option? Because typically you see people are on those medications for almost the rest of their lives to keep that weight loss off. And so then you do look at and consider, what if we allow bariatric surgery, where that's a one-time event, and if it works well, they lose the weight and they're not continuously on this medication, that might be more costly in the long run. So just one of those considerations that's out there in any health plan design.
All right. Another question we have, if our organization is a healthcare provider, how can we leverage our own internal services with a self-funded plan?
Oh gosh, I love that question. And we have quite a few medical providers, and one of the things that goes back is what is the company culture, what is the leadership aspect of that. Now, I will also say I have various ranges of some of our healthcare provider groups that are self-funded. Some of them are very transparent about the fact that they are self-funded and the fact that all the decisions that the providers internally make do impact their bottom line as far as the cost of their health insurance plan. So they're more bought into the concept of prescribing generics over brand name or specialties if there's an opportunity for that. And so to go back and help answer the question, is being a provider yourself, that is a great opportunity to kind of have an internal powwow of having that discussion to say, hey, we're looking at going self-funded. How can we communicate this to not only our providers internally, but our admin staff and things like that, to truly develop a great culture around why we're choosing to use? What is the investment that we have? You also want to make sure that you have some of those proper safety mechanisms in there, like HIPAA certified officers, right? Because you do potentially have coworkers going to see other coworkers. And so you want to build a culture around safe communication and things like that, that knowing if I'm going to a fellow coworker about a situation, an issue that I'm having, that it's still going to stay between me and my doctor, just the same as if I worked for any other company. If I worked for a construction company, right, and I go see my doctor, I'm not expecting my doctor to go tell my coworkers some things. You want to have those same expectations, even though you're in a provider setting. But then really, this is where I'm a few years shy of my medical degree, where you're able to make a lot more of those, medical decisions based off of actual, medicine proven decisions. So in that way you can help your members guide through the healthcare system and potentially at a lower cost because you're getting it done internally rather than paying another provider externally.
Yeah, and we had a really interesting comment that I think definitely kind of really it shows the mindset of self-funding. Was somebody in the comments had shared, well, if I have folks that want to take, this weight loss drug, if they aren't obese, or it takes them in a healthier direction, does that potentially eliminate future health risks? And so what I like about, and I mean, correct me if I'm wrong, but what I feel like being in a self-funded environment does is it allows for conversation, right? If you're fully insured, your fully insured carrier is just going to say the medical director said no, so the answer is no. Whereas when you're self-funded, you have an opportunity to engage in communication with your stop loss carrier, explain the reasoning, have an opportunity to show the data and say, well, if we cover this is what potential risk we're avoiding. And it at least, in my opinion, opens up some dialogue at the very least. I don't know if you'd concur or but what has your experience been with having those kind of conversations?
Yeah, I mean, it's great because, right, every employer has different opinions, different thoughts about these all these different coverages, right? I mean, we can talk about specifically the weight loss prescriptions, and that's a very hot topic about what's going on. And that can range from groups are fully bought in and they want to offer that to their employees, and they're okay with that and they want to go forward with that. They believe in that. Some are on the opposite side where they say that's not for us. If it's not approved for most carriers, we're not going to approve it being a self-funded plan. So somewhere maybe in the middle is, typically where most people lie. And one of the things you can kind of do with that is, well, a lot of the employers here were like, well, we're not medical physicians. So one of the things you can help implement is maybe one of those vendor partners that we work with, and they might have a system or a program that helps walk people through, similar to what happens in bariatric surgery, where there's a pretty extensive background process that has to happen before somebody goes through bariatric surgery. And a lot of that is simply like changing mindsets and habits and things like that to ensure that you're not going to go get that surgery and then just put that weight back on. And it's very similar with this medication piece. Is there's a psychological aspect of that to make sure that members are going to have the right approach when they're coming to take this medication to maybe lower some of their weights and other metrics that help them become healthier in the long run. But how can we develop healthier habits along the way to make sure that once it's time to start weaning off of that medication, that you're not going to go back to the old habits that kind of got you to where you were previously. Best way that I know how to talk about that, I guess. A few years short of my medical degree.
All right, we're going to close out with just a few more questions. And I think this one, more on the compliance side of things. And I think my caveat is going to be that what I referenced earlier, we're not lawyers and we're certainly not tax professionals. And so this is going to be a best practices kind of answer. But one question we had was regarding any requirement to set up a trust when it comes to having a self-funded plan. And just knowing from my experience that there are certain types of entities, especially publicly held entities or government entities, where there are strict rules about, you need to have any of those funds for the claims and the costs set up in a trust, and that there's some funding requirements. As far as what those requirements are, it's going to vary state by state. And so, without knowing what state this person's in, I would say it's kind of hard to know, but it is good to be aware of that. Yes, if you are a public entity, there are some additional requirements. And even if you're a private entity, James, I know that you recommend to all of your clients, like, hey, you don't want these funds moving around in your general operating budget. You generally want them in their own account. And can you speak to the fact, the fiduciary responsibility that comes with the self-funded plan?
Yeah, I mean, very similar to obviously ERISA, originally kind of starting specifically with retirement plan protection. There is as a fiduciary of your funds, if you will. That is one of the things, is rather than having your funds be in the general account and things kind of coming and going as far as fixed costs, variable costs, things like that, we do recommend having a separate bank account, if you will, to be able to track specifically your health insurance funds. That way, again, being one of the positives being self-funded is if you spend lower than what our projected claims amounts are, that's money that stays in your bank account versus paying 100% of that fixed cost over to that. And so what Aaron was kind of mentioning is things like having to set up trust and having fully funded claims amounts and things like that. That is very much a case-by-case scenario. And so that is typically where we will either bring in our legal aspect to walk through those considerations there, and or your tax professional as well. So sometimes there are different moving parts from that perspective where you have to consider bringing in a team of professionals to build something that's potentially a self-funded plan.
I think it's worth noting that while James and I aren't lawyers, we do have for our self-funded clients, we do have a wonderful, vendor partner that offers that legal guidance. And so just because we're not lawyers doesn't mean you don't have access to them.
I know a person.
Just not personally. No.
Yeah.
All right. We're going to close out with one last question, James. And I like this question because I feel like it ends on a high note. And it's, what's the reality here is, in your experience, how long does an employer have to be self-funded before they start to realize plan savings?
Great. That's a great question. And it depends. No, always a classic answer. It depends. But I'd certainly say one of the availability and why we kind of ended with this slide specifically here is it's really an open road. And so as I kind of alluded to, the renting versus owning mentality, if you want to go and purchase the very similar experience like renting a car, you might have a little bit slower of a time adopting and going through that. But if you want essentially to put your pedal to the metal and just go for it and implement different cost containment tools and different mechanisms in there, you can get to that end goal a lot quicker. Now, some of that consideration is like, well, how's your suspension? How's that bumpiness of that plan going to be if you're going pedal to the metal, right? If you introduce something that's going to have a lot of experience with your members who are going to have to now change doctors, change prescriptions, things like that, what's the experience versus what's the cost impact of that? Now, typically, we see data starting to flow after 6 months. We would certainly say it's not necessarily credible data because claims lag that's in there. Typically, we'd say about 2 years is when you'd have credible data to be able to go back and look at kind of what we say the rear view mirror, where we're looking at what is your historical claims and what does that look like? So if we do make any plan modifications, historically, here's how that would have impacted. Now, we try to match that as well as with the windshield version, where you're looking at what's ahead and what has our experience been if we implement XYZ vendor there. And so this is where you have a lot of that flexibility where it's like, okay, right now our issue is maybe we've got 3 or 4 people who have cancer related things. We implement a program in there. We do some additional testing, incentivize, communicate that happens, and we are able to help bend that down. But let's say in 2 years from now, after we're able to communicate that, now we're seeing a trend in some diabetes type things. Well, now we're able to adjust our plan, adjust our communication, and maybe add in a vendor partner that specifically tackles that specific problem. And you're able to do that through having that data in there rather than being a reactive on the back end where you're just getting told at renewal time, here's your high cost claimants, and there's not really a whole lot of solutions for that. So I don't know if that exactly answers all the questions in there, but I would definitely say the gas pedal analogy is a big thing of saying when you're self-funded, you get to control how fast you go. You also have to have the other considerations of the faster you go, it might be a little bit bumpier. So we have to weigh those pros and cons.
Yeah, I especially like, thinking about, okay, if you're fully insured and you're getting a 10% renewal every single year, it's like boiling that frog. You don't really notice until 10 years later, you go, wait a second, my healthcare costs have doubled. Awesome. Well, thank you so much, James. I really appreciate your time today. Thank you, everyone, for attending today's presentations. SHRM CE credit for attending today's webinar will be sent in the next few business days following verification of attendance. If you have any further questions about anything that you heard about today, please don't hesitate to reach out to us at Advanced Benefits. We can be reached via email at info@trustab.com or via phone at 208-664-3482. We hope you found value in today's presentation and wish you all a fabulous afternoon. Thanks so much, everyone.